Psoriasis is a chronic, multifactorial, and inflammatory skin disease characterized by the rapid proliferation of keratinocytes, leading to thickened, scaly skin. It predominantly affects areas such as the elbows, knees, scalp, and lumbosacral region, but can also extend to other body parts, including the glans penis and intergluteal clefts. In up to 30% of cases, psoriasis extends beyond the skin, affecting the joints and leading to psoriatic arthritis. The management of psoriasis is multifaceted and is guided by the extent of skin involvement, specific body sites affected, and the presence of joint involvement. Background: psoriasis is a non-contagious chronic inflammatory disorder that primarily affects the skin and, in some cases, the joints. Patients with psoriasis often have a genetic predisposition to the disease, which typically manifests in the skin of the elbows, knees, scalp, and other specific regions. Psoriasis tends to follow a relapsing and remitting course, with periods of flare-ups, often triggered by environmental or systemic factors, such as stress or infections. The condition significantly impacts the patient's quality of life and has been linked to an increased risk of depression. The most common form of psoriasis is plaque-type psoriasis, which presents as raised, inflamed plaques covered with silvery scales. Other forms include guttate, inverse, pustular, and erythrodermic psoriasis, each with distinct characteristics and areas of involvement. Pathophysiology: psoriasis is believed to arise from a combination of genetic predisposition and immune system dysfunction. The exact mechanisms underlying the disease are complex and not fully understood. However, it is known that psoriasis involves an overactive immune response, particularly involving T cells, which leads to inflammation and the rapid turnover of skin cells. Normally, skin cells are replaced every 23 days, but in psoriasis, this process accelerates to 3 to 5 days, resulting in the characteristic thickening and scaling of the skin. Histological studies of psoriatic lesions reveal an infiltration of T cells in the dermis and epidermis, along with a high concentration of pro-inflammatory cytokines such as TNF-α, IL-17, and IL-23. These cytokines play a key role in sustaining the inflammatory process and promoting keratinocyte proliferation. Etiology: the exact cause of psoriasis remains unclear, but a combination of environmental, genetic, and immunologic factors is believed to contribute to the development of the disease. Environmental factors: triggers such as infections, cold weather, trauma, stress, and certain medications, e.g. beta blockers, lithium, can exacerbate psoriasis. Some patients also report that sunlight and hot weather alleviate symptoms, although this is not universal. Genetic factors: psoriasis has a strong genetic component, with certain HLA alleles, e.g. HLA-CW6, being associated with a higher risk of developing the disease. In some families, psoriasis is inherited in an autosomal dominant pattern. Immunologic factors: psoriasis is considered an autoimmune disease characterized by excessive T cell activity in the skin. This leads to the release of pro-inflammatory cytokines, which drive the pathological changes observed in psoriatic lesions. Interestingly, the disease can worsen in HIV-positive patients with decreasing CD4 counts, indicating a complex interplay between the immune system and psoriasis. Signs and symptoms: psoriasis presents with a wide range of clinical manifestations, depending on the type and severity of the disease. Plaques: raised red patches covered with silvery scales commonly found on the scalp, elbows, knees, and trunk. Guttate lesions: small drop-like spots on the trunk and limbs, often following a streptococcal throat infection. Pustules: white pustules surrounded by red skin, often localized to the palms and soles. Nail changes: dystrophic nails that may resemble fungal infections. Joint pain: psoriatic arthritis affects approximately 10 to 30% of patients, causing pain and swelling in the joints, particularly in the fingers and toes. Diagnosis: the diagnosis of psoriasis is primarily clinical, based on the appearance of the skin lesions and their distribution. Different forms of psoriasis exhibit distinct clinical features, aiding in their identification. Chronic stationary psoriasis, the most common form, characterized by well-defined plaques on the scalp, extensor surfaces, and lumbosacral region. Guttate psoriasis typically occurs on the trunk, often following a streptococcal infection. Inverse psoriasis affects flexural areas such as the armpits and groin, often mistaken for fungal infections. Pustular psoriasis presents with pustules either localized or generalized. Erythrodermic psoriasis, a severe form involving widespread redness and scaling over the entire body. Testing. Although no specific laboratory test can diagnose psoriasis, certain tests can support the diagnosis and help differentiate it from other conditions. Rheumatoid factor and ESR, typically normal, but ESR may be elevated in severe cases. Uric acid levels may be elevated, especially in pustular psoriasis. Fungal studies, important for ruling out fungal infections in nail or foot psoriasis. Radiographs and bone scans, useful for assessing joint involvement in psoriatic arthritis. Management. Management of psoriasis is tailored to the severity of the disease, the areas of the body affected, and the presence of associated conditions such as psoriatic arthritis. Treatment options include topical therapies. Corticosteroids, vitamin D analogs, retinoids, and coal tar are commonly used for mild to moderate psoriasis. Systemic therapies, methotrexate, cyclosporin, and biologic agents targeting specific immune pathways, e.g. TNF inhibitors, IL-1723 inhibitors, are used for moderate to severe cases. Phototherapy. UVB light therapy is effective for widespread psoriasis. Lifestyle modifications, stress reduction, weight management, and smoking cessation can improve outcomes. Epidemiology. Psoriasis affects approximately 2 to 3% of the global population, with varying incidence rates depending on geographic and ethnic factors. It can occur at any age, with peaks in the 20, 30, and 50 to 60-year age groups. Women are slightly more affected than men, although men are more likely to experience ocular involvement. The disease is less common in tropical regions and among individuals with darker skin tones. Prognosis. Psoriasis is a lifelong condition with periods of remission and exacerbation. While mild psoriasis does not significantly impact life expectancy, severe forms are associated with increased mortality, particularly due to cardiovascular disease and other comorbidities. Patients with psoriasis are also at higher risk for depression, metabolic syndrome, and certain cancers. Despite these challenges, advances in treatment, particularly biologic therapies, have improved the long-term outlook for many patients. Conclusion. Psoriasis is a complex and multifactorial disease with a significant impact on patients' quality of life. Understanding its pathophysiology, triggers, and management options is essential for providing optimal care. Ongoing research into the genetic and immunologic underpinnings of psoriasis continues to drive the development of more targeted and effective treatments, offering hope for better disease control and improved patient outcomes in the future.